Oscar is proud to be here alongside the Morris County Chamber of Commerce and our host, the Morristown Medical Center. If you'd like, join the conversation on social media with the hashtag HiOscar and the Twitter handle @OscarHealth. Finally, a special thanks to Paul Bedreau, who helped us pull this off. Mario Schlosser is CEO and co-founder of Oscar Insurance. He was previously the founder and chief scientist at Vostu, the largest mobile gaming company in South America, as well as a senior investment associate at Bridgewater, the world's largest macroeconomic hedge fund. Dr. David Shulkin is president of Morristown Medical Center. He was previously the president and CEO of Beth Israel Medical Center, as well as chief medical officer of the University of Pennsylvania Health System. Finally, David Knowlton is president and CEO of the New Jersey Healthcare Quality Institute. He was previously the deputy commissioner of health for the state of New Jersey during the administration of Governor Tom Keene. Additionally, he served as executive director of the Healthcare Payers Coalition of New Jersey, an organization for which he still serves on the board. I've partitioned these questions into 3 general topics. They are the consumer experience and affordability of care, the role of technology, data, and transparency in health, and the state of our healthcare system. I'll direct each question to one of our panelists, but I encourage all of you to jump in briefly if you have some additional thoughts you'd like to add. So first, the consumer experience and affordability of care. Dave Knowlton, healthcare costs are notoriously high in the United States and growing at an alarming rate. What do you feel are the most necessary changes to reversing the systemic trend and creating a more affordable healthcare system?
Well, I think that changes are already underway, as some of what you're seeing here. The most important thing is value, seeking value for care. But to get value, you need transparency. We don't have we need this healthcare system to act as a market. For it to act as a market, it doesn't act as a market now. You don't have price information. And even as you see here, you have information about, a lot of information about a doctor, but it's not saying this doctor is better than that doctor. This is the doctor you want to go to for your daughter's ear infection. Are you sure she needs amoxicillin yet? Because we overtreat with antibiotics for otitis media. We need that type of information integrated into the system with cost so that consumers can make an intelligent decision. You have more information about a washing machine you want to buy than about a healthcare you want to buy. So we're going to be moving to platforms like this, I hope, and that's really the change agent, but I'm going to kick you to move it even further. I think we gotta go for value.
Mario, you're building a consumer-focused health insurer driven by technology. What are you and Oscar doing to make sure that these advances meet the needs of the consumer? As you've thought about how to deliver on this promise, what have you come to believe is most important to today's healthcare and consumer?
Yeah, I think the most important thing is really to start with what kind of user experience, member experience do you yourself want? And so when I use our own tools on behalf of my kids, for example, on my own behalf, I use the tools not so much as the CEO of Oscar, but really as a consumer of the healthcare system. I want to see that these tools become useful for me in navigating the system. And probably the most important thing really is orientation. It is a tremendously complicated system. We in New York, for example, have 40,000 physicians in the network. We have about 80 hospitals or so in the network, just in the 9 downstate counties where we service in our service area in New York. Getting more orientation as to which doctor is even open when I need him, as to who is the best doctor to see for a particular condition, etc., is incredibly important. And there are very, very few sources of information like that right now. There are even fewer sources of information that will provide you this in a customized way to the health history, to the particular situation you are currently in. If you're really looking for a doctor in New York, as an example, that's is a otolaryngologist that sees a lot of toddlers, for example, there is almost no way of finding that, except for, again, if you use an Oscar tool, for example. So orientation, incredibly important. It doesn't stop there, though. I think we're also seeing a ton of change in healthcare at the moment, I think in great ways when it comes to the delivery of care. We're seeing the emergence of more and more urgent care clinics. We're seeing the emergence of televisits, for example. And we are very active in sort of thinking through how can we kind of rewire these emerging pieces in the healthcare system and make them more available and get people easier access to care in many ways. And so you saw in the demo that I think we're the first insurance company across the country that's enabling members to get 24/7 totally free televisits, meaning visits to doctors over the phone. Tremendously important. As I mentioned, we see some care shifting over. One statistic we just saw last week from 2014 is that in our own membership base, when you look at the under 35-year-olds, for example, you look at episodes like bronchitis. Then in the last year, about 60% of all of our bronchitis episodes now shifted over to televisits and were completely concluded there, meaning from start to finish, everything went over the phone and was concluded over the phone. And that's a quite powerful shift and it creates a lot of convenience, I think, for the member. So those are the two big pieces I think that are needed. Orientation, more orientation for the average consumer in the healthcare system, and then easier access, more convenient access to healthcare when needed.
Dr. Shulkin, the Affordable Care Act has made insurance available to millions more Americans who previously lacked coverage. Presumably, this will mean an influx of new patients into the healthcare system. What do hospitals need to do to accommodate this? How can we ensure great care for this newly insured population?
First of all, I just want to welcome everybody to Morristown Medical Center. Thank you for coming. If you've not been here before, if there's anything we can do to help you during your visit, please let us know. And we're glad to have you here. Secondly, and maybe this is because the medical profession has so ingrained this in us, I just wanted to disclose a conflict of interest, which I don't have any. Oscar, I have no relationship with Oscar. They don't pay me for this, and I'm not. Some people ask me if that's me on the that's not me, although it looks like me. So, but thank you for asking us to participate. And I will get to your question, but I wanted to comment on what the two of you said. I desperately want to believe your answers, that this is what we have to do in healthcare. We have to let people have information, transparency, and we have to make the user experience correct, and that's going to fix healthcare. I would love to believe it. I just don't believe it. And we have the experience, just for all of you to know, that we have had, and I'll use the example of cardiac surgery, we have had mortality rates by doctor available for what, Dave, 15, 20 years?
Mm-hmm.
on the website. So in other words, you can go, if you're going to have cardiac surgery, open heart surgery, and find doctors who have 5% mortality rates and doctors who have less than 1% mortality rates. And I still can't figure out why anybody would want to go to the 5% guy. Why wouldn't everybody want to go to the guy who's less than 1%? Our cardiac surgery program here is less than 1%, one of the best, certainly the best of every New York City hospital, every New Jersey hospital. Why wouldn't everyone want to go here? It's all public. And yet it doesn't happen. Mm-hmm. There are cardiac surgeries happening at hospitals all throughout New York City and New Jersey today, not here. So there's a mystery about why this information doesn't change behavior. And as Dave knows, 15 years ago, I thought you were exactly right. I quit my job. I raised venture capital money. I started a company to do exactly this. Right. That's where Dave and I met 15 years ago. Mm-hmm. People didn't use the information. So there's a mystery out there.
You were too much of an idealist, David.
Yeah. No, but there's a secret sauce that I really hope you discover because I believe in it. But the reality says that somehow people don't use this information to make better decision making, and I still can't figure out why. But anyway, that's the challenge. You have an answer?
I think a couple of things that come to mind very briefly. One is I do think the system is changing, right? Yes. 15 years ago, you didn't have high deductibles, for example. Yes. High deductibles put much more responsibility on the part of the patients and the patient's pocket really to make better decisions from the very beginning. That wasn't the case 15 years ago. It's the case in the last 5 years or so, if anything. And the other point always is, I've tried to get those mortality rates myself before we started out. I've tried to get C-section rates at hospitals where my kid could have been delivered. It is almost impossible to find where those would be. You have to literally, in New York at least, petition the states to get the Sparks data, which is inpatient, outpatient, kind of like case data and so on. and tell the state what you're going to do with it. As a consumer, that's a ridiculous proposition. And so I do think part of the answer is it's got to be done incredibly well and useful to the consumer. But that's still a tall order for sure.
There's no question high deductibles is a game changer. That theoretically really should have an impact. The issue about the availability of data is still questionable. I agree with you. Very, very hard to get real quality data. I mean, Dave works on this full time. It is hard. But what I'm saying is, in the examples that we know the data's out there, right. Mortality rates by doctor, information about mortality rates by hospital, which is available on healthcare.gov, okay? We're still seeing the hospitals with bad ratings still filled with patients. Yep. Hard to understand. It's sort of a mystery. That's and I hope that you're on your way to figuring it out. And I know this is what Dave does for a living. I'm still not sure that there's not something we don't understand yet. Mm-hmm. Now, I think back to the question, which to remind the audience was, so the Affordable Care Act happened. What are we seeing at hospitals, and what should hospitals be doing about it? If you give people free insurance and they didn't have it before, they use it. And that's what we're seeing. We're seeing rates of utilization at hospitals and doctors going up. In areas like Morris County, which are relatively affluent, not as much as in inner city areas where states have done the Medicaid expansion and more people in inner cities who didn't have insurance now have insurance. We're seeing the utilization rates of hospital emergency departments of hospitals and physicians up high. But even here in Morris County, we are seeing an increased use of hospitals, doctors, and emergency rooms. And that's the intended impact, I think. And so we're seeing that, and I think that is beginning to work. Now, what do hospitals need to do to respond to that? I think ideally you would like to have all these people with new insurance products to have primary care doctors. It is very hard, and I'll talk about Morris County, it is very hard to find a primary care doctor who doesn't have a long wait list. I am a primary care doctor. Good luck getting an appointment with me. I mean, we have very, very large demand, and the average age of a primary care doctor in Morris County is 56 years old. They're not adding new partners to their practices, and so hospital systems like mine are trying to bring in new primary care doctors, expand residency programs to keep people in our area, try to set them up in hospital-employed practices and try to meet that capacity. We are doing it with some success, but not a lot, and that's why our emergency rooms are getting busier, and they're getting busier with people that may not necessarily need to be in there. You're seeing right now urgent care centers in every neighborhood in Manhattan, on every block, replacing some of the nail salons and stuff. And that's interesting. My personal opinion is this is a bubble with urgent cares. I mean, there's going to be so many in this country pretty soon that I can't imagine they'll all be busy. But we are seeing this immediate access, a need with all these people. I think what hospitals need to do, besides focus on primary care, is get people in a system of care, because primary care is one piece of it. But when you have people who come into the system with chronic illness, they really need a team-based approach towards chronic illness management. And it can't necessarily be episodic. And that's one of the things that, as you're thinking about your system, it seems to me, again, just from watching your daughters, it may be episodically based. And I think, where we want to transition that for people with chronic illness is towards a team-based approach of care.
Can I take another shot at this? I can't let that all go. I assume you want controversy here. Number one, I think that David's right, that consumers aren't tracking mortality rates by surgeons. It's not a very good differentiator. The intention of that, the effect of that, when we first started reporting cardiac surgeon rates, I was Deputy Commissioner of Health. That was a long time ago.
Yeah, long.
And what happened is the death rate from cardiac surgery plummeted when we started reporting it. These people weren't the target, you were. You know, I wanted hospital CEOs to say, we got to get a better rate. And they had to cramp down on their surgeons, and they did. And you get good programs like you have at Morristown because CEOs give a damn about it, and they change it. Absolutely. Now we're moving to a time when consumers get actionable information, which blends mortality rate, which is a very blunt instrument, with do I really need the surgery? And if I do need it, is it minimally invasive? And what's the blood loss? And what's the time on the table? And do I have postoperative nausea and vomiting? And do they have to use a rescue drug? And all these other things that are really matter to consumers. And they dovetail that with experience of care. You know, so how did I feel? Did the doctor, was he a jerk? Was he understanding? Was I treated well? The things that frankly, your hospital does well, because you pay attention to it, is what consumers, but they can't get information like they could get about the local Hyatt looking up on TripAdvisor, because I think that's going to happen. Secondly, on the primary care's dead. You can buy all the primary care practices you want them. They're gone. Televisits, telemedicine. I don't think there's a primary care doctor left in Manhattan. You know, people don't use primary care. Their primary care becomes specialists. If you have AFib, your primary care is a cardiologist. If you have diabetes, your primary care is an endocrinologist. And that's not good, because to the cardiologist, the interest ends between these two lines. You need primary care attached to a specialty practice, so that every other visit with your cardiologist includes a primary care workup that doesn't just look at your heart, looks at your endocrine system and your kidney system and all the other stuff. So I think that this is a really radically evolving system. And I believe that the winner is going to have a platform. I don't mean to tout yourself, and I'm not on your payroll either. But I think you're going to see these types of systems. And we're delivering medication in the outback of Haiti now using drones. You know, we gotta think out of the box in this system. That's smart. I'd rather deliver medicine in Haiti after an earthquake than bombs in Iraq. I think it makes sense. We gotta think out of the box with what this brings us. And these are some exciting things. And as I said to you before we started, what I like best about Oscar is he's a change agent. He's pissing off a lot of people, and that's good. It's going to shake up the system a little bit. That's a good thing.
Thank you. One more thing as well. I think from a consumer perspective, a lot of things in healthcare just lack from an end-to-end usefulness. You know, it is one thing if you can go and download an Excel spreadsheet of mortality rate by a cardiac surgeon, and then try to convince the doctor who told you got to get surgery that you want to get admitted to that hospital, etc. It's never sort of like this end-to-end useful experience. And I do think now increasingly also with the delivery of new types of care like televisits, like urgent care, etc., whether it's right or not, you can create more and more this orchestrated end-to-end useful experience. And so what we would want to do is essentially say, once we've seen the hospitals that have the lowest mortality rates for certain things, we'll even take out the doctors from the care routing system we have that admit to other hospitals. And that's certainly where the system becomes more end-to-end useful, more radical, and rerouting people to the right point of care. But you're absolutely right. If you only do one of the 10 things that's needed to do that, you're never really going to get there. That's true.
Well, then you were talking about the complex patient, the chronic patient. We don't have complex patients. We have a complex system. And so the sicker you are, the more chronically sick you are, the more difficult it is to navigate. So think of somebody that finds out that they have a bad cancer. The issues that they have to confront and how they get access to care during this whole thing is very complicated. So simplifying this so that it's that new consumerism. And hospitals with the brain power and the assets, Morristown would be one of them, are going to be a change agent because they can afford to make those type of changes. And the big challenge is, can we bring it also to those poorer hospitals and safety nets that are in the inner city? That's going to be a challenge.
Dr. Shulkin, interpret your argument to be that there's just not, even with the information available, even if all consumers had wide access to that, they're not making the proper choices. And so if that's the case, people like Cass Sunstein are big fans of the notion of nudge, behavioral on economics. Do you think that that's an appropriate use in this situation in healthcare? Do you think we should be nudging people in the right direction, guiding their path, sort of maybe even without them fully aware of it?
This to me is the big issue that employers are going to have to make in the next couple of years on private exchanges. The private exchange issue, to me, is a philosophical issue, which is, do you just give the people their money in the high deductible plan and get out of it and say, look, let people decide on their own the way that they would buy a washing machine or the way that they would buy a car. You put the information out there and let people decide, or do you actually help them make decisions because somehow healthcare is different and more complex? And there are, as I'm sure everybody here knows who's dealing with healthcare and healthcare benefits, industries of consultants and analytic companies and algorithms that are helping people make better decisions about where to purchase care and when to get care and all that. I guess that if have to make a choice, I guess I'm a nudger. Maybe it's cultural, and my parents told me, nudge me enough. But I still believe that healthcare is complex enough that people do need some help with decisions. Now, we've been way, way, way too far the other way. We've been way too paternalistic and haven't treated consumers as adults and that they can make decisions. So I think, Oscar and other people, what Dave does is pushing us absolutely in the right direction. Much more transparency is needed. But I do think that there still is going to be a role, I think, as Mario was saying, in this user experience to help people, maybe like on Amazon, it makes recommended choices for me. Hey, if you have this problem, we might recommend that you see or that you go here or wherever, still allowing ultimately the user to make the choice, but helping with some information. Yeah. So I think I'm a little bit on the nudging side.
One anecdote real quick from a data perspective as well on this. We in New York became, and now in New Jersey as the next step as well, in New York we became the first insurance company to tap into the local regional health information organization. In New York it's called HealthX. So those are organizations, there's one in New Jersey as well, the New Jersey Health Connector I believe, that essentially go to hospitals and connect up the electronic health record systems. So that's when you, for example, original purpose I think was when you get delivered into the ER, you're unconscious, the doctor can log into the system and can see your recent health history with the admits in other ERs, other hospitals, etc. We petitioned that company, that organization, said, can we get for Oscar members who give us the permission to do so, download their previous health history from pre-Oscar days. And together with that, we also are getting a real-time feeds of when somebody gets checked into an ER anywhere across New York City, so we can react to it right away. And we put, so again, we have to ask you for permission as Oscar member, can we do this importing? And can we get this real-time feeds? And when you onboard with Oscar, when you create a website account and you became a member, there's a screen that basically asks you exactly that. Can we import this data for you? Do you want us to do it? And it was, for me, a total crapshot, frankly, as to whether people would say yes or no, because this really is your insurance company that may deny you care. Who knows? You don't know how these big brother type insurance companies work, asking you for more information about yourself. And when we put exactly what you just said, when we put there saying, we are going to use this data to recommend you better care. Literally, I always also like to use the Amazon example. That's when people started to 80–85% or so saying, yes, please do this for me, because they want exactly this kind of assistance with some care. And I also think if you leave it to the usual suspects, it won't really work. A big insurer that shall not be named in New Jersey called its plans in the exchange Advantage and Advance. One of them has a tiny network, one of them has a big network, and it's very hard to impossible, I think, for consumers to understand that difference when the names are even so similar. Even brokers have tough times deciding between this, and so I do think you need this nudging, you need the support, this assistance with this data.
Private companies, be they Oscar or other ones, are hopefully making incredible leaps in the healthcare space, some of which we've discussed and shown. The space is also incredibly regulated. How do you see that playing out? You know, I think one good example is we've discussed teledoc. There are certain states that are, you know, looking to make that more difficult, looking to, you know, ensure that there's that face-to-face connection first. How do you see the regulation of the public sector and these innovations in the private sector playing out? Very complicated
issue. A couple of examples. The short answer is the regulators, and I've been one, have to get smarter. They have to get more agile in dealing with this. And I can give you a couple of examples. Teledoc is one of them. The ability to do telemedicine shouldn't have protectionism behind it that says, you know, we can't do that. You got to have a face-to-face visit. That's an economic issue. But whether you want to trash states' licensure rules and say the teledoctor can be in Singapore and calling in without any regulatory oversight and without any legal redress if a patient is harmed, I'm a little bit more skeptical of that. You know, so they have to be a little more agile, and regulators by definition are not generally agile. So let's look at the pharmaceutical industry, always a big issue whether you're in the medicine cabinet of the country here. Take the drug Sovaldi, which is the Hep C drug, $84,000 for a 12-week course of treatment. That treatment, however, cures. It cures. So you can get a drug that can cure something for $84,000, something that causes all kinds of liver damage and exclusive, not to mention mortality, okay? Maybe not a bad investment. People look at that and say, oh, what do you mean? And I say, well, what's the treatment cost of Hep C? So we got to think out of the box a little bit. And it's easy to say, oh my God, can you imagine $84,000 for a 12-week course? Probably a good investment for Medicaid, you know, which is, by the way, where a lot of the Hep C is. Probably a good investment. I was saying that to an important person in government recently, saying, don't throw that baby out with the bathwater. That's saving you a lot of money. You're not looking at it logically. So regulators have to have a little more insight. They have to slow down a little bit. This is a rapidly changing market. And these things, we do a course called Policy 360 at Rutgers for people that, it's an immersion program, 8 segments on health policy over 4 days. And in that program, I always begin my first slide is a blank slide, with breaking news that occurred within the past 18 hours in healthcare. That's how rapidly this market is changing. And they're all game changers. I'll only put a game changer on that slide, and there's always 4 or 5. It's the nature of the healthcare market now. And the regulators are way back here. Well, they got to get up here and start asking some important questions. And health insurance companies need to ask those questions. Getting good, minimally invasive, early, appropriate surgery, particularly in cardiac, may make more, at a top hospital with a low complication rate, may make a hell of a lot more sense than going through 17-step programs and tiering systems, which are going to cost a lot more money over time, but allow you to regulate a mass instead of the individual patient that's before you. Other than that, I don't have an opinion.
Mario, Oscar is, you know, potentially at the front, the vanguard of the health insurance industry. With respect to tech, data, transparency, what areas are you most excited to see advancements in?
I think real-time data, real-time information is another one of those things that's really generally missing in people's healthcare experience. Literally in my case as well, when my first kid was born, we came out of the hospital 3 days later, and on the same day rushed back to the hospital because we thought he stopped breathing, and it was only really, he had just not gotten enough milk pretty much, and we freaked out about it, as new parents do. And so once you're in the NICU, you're in the NICU for 4 days, and they watch him, and they teach you how to feed him properly, in our case. And so 2 months after that experience, at the time we were still with United, I shouldn't probably name the insurance company, with a big insurance carrier, I got a call from a cheerful United nurse saying, oh, we saw you had a new kid, it's on the record now here, and just want to check if everything's okay. And I said, I guess except for this $100,000 bill you guys paid for this NICU stay, that was probably also not really necessary. So it was this odd experience where the total lack of real-time information that's really the healthcare system overall almost has in like a very odd way, because no single entity in the system has a full overview of your full scope of care. The hospitals see what's happening in the ER, but not what's happening in the PCP practice, unless, of course, they build more, they expand more to them. The doctor doesn't see when you go to the ER. Is a real issue, I think. And so I am excited about anything we can do to get a little close, to get much closer to the consumer and the members' individual healthcare experience as it happens. We like to joke that Amazon knew that my wife was pregnant long before my insurance company did at the time, you know. And so everything, and exactly. And so a lot of things we do go towards that direction. The powerful thing about actually administering these televisits, in our case, we built a very direct system to, or link to Teledoc system. Teledoc doctors take the phone calls, but we immediately get the records back into our own systems. Powerful thing about that is that our own nurses in-house can read these clinical notes coming from these doctors in real time as they hang up the phone, and then see if there's anything going on that requires a follow-up call. And we had situations where members tried to fill insulin over a televisit phone call, did it once, maybe goes on vacation, forgot to fill it, but did it a second time. It turns out member was not in treatment with a PCP. Diabetes type 1 would have gone to the ER within basically days or weeks of this particular episode. Our nurse drove out to meet him and walked him into a new PCP practice. He didn't like his previous doctor, stopped going to him. And so these real-time interventions, I think, are incredibly important. And I'd love to see how we as an insurance company can connect much more closely to the healthcare delivery system, because of course, again, it's not sustainable for us and scalable for us to have doctors and nurses on our own staff in the way it would really be needed to service millions of people. That's really only doable with the system.
Dr. Shulkin, I'd like to pose the same question to you, but from the hospital's perspective. You know, how do you see these advances coming about? What do you think we should be focusing on with respect to data and tech?
Yeah, you know, I unfortunately, you know, end up agreeing with both Dave and Mario very much in their perspectives. I think that the issue of data and technology, we need to get it much more into the patient's hands so that they become a meaningful decision maker, a meaningful partner along with the provider system. And I'm still open-minded about the insurance company. You know, I think the insurance industry has time and time again blown the trust factor with both the providers and the patients. So I think you have an uphill battle to you know, get the trust of your subscribers. The fact that you're getting 85% agreeing, I think, is a very, very good sign. I also find myself agreeing with the fact that information at the time that people are faced with healthcare decisions is the most important time to get them the information. When you listen to Mario speak, it's amazing how many times he refers back to his experience with healthcare with his children, because that's impactful for him, and it's a very good learning experience. Just wait till you get older and you get some real diseases. You know? But if you think about people and you think about all yourselves, it's when you or your family members interacted with the healthcare system that it really got you thinking about the problems in the system and what worked and what didn't work. And so what I think hospitals need to do, since we take care of people at their greatest healthcare challenges, when they're really facing a crisis, we need to, in some ways, take advantage of that, to use that as the way to engage them in their own healthcare. So one of the things that we've done here, and we're the first hospital in the country to do, if you came in through our main entrance of the hospital, I don't know where you parked, there's a lot of ways to get in this hospital. We have on our first floor the world's first app store in a hospital. And the reason why we've done that is because when somebody comes in and they've had a heart attack, and they're now upstairs in our intensive care unit with a heart attack, and their family's visiting them, this is the time that they're most willing and interested to look at their own lifestyle interventions and to develop a care plan. So we actually write a prescription that they can take to our app store, like a prescription you would take to a drugstore, that says, you've been recommended an app on how to manage your cholesterol, how to manage your blood pressure. And they go in, and their family members, or if the patient can, we explain to them and take their phone, load their app for them, and explain to them how to use this and how they should use it. So it's trying to engage the patient with their own information at the right time. I think the provider is a key piece of that. I think you're trying to make the insurer be a key piece of that. I think working together could be very powerful.
Mm-hmm.
So final section, I'm going to have the same question for all three of you. I'm going to ask you guys to keep it brief only because I want to make sure we have enough time for questions from the audience. How do you see the American healthcare system evolving over the next 5 to 10 years? What are your concerns? What are you excited about? Why don't we just go down the line? We'll start with you, Mario.
To pick up on the last thing, I think you said the closer cooperation between insurance companies and providers, incredibly important. I think that's, I'm amazed by the gates we, even as Oscar, put up when it comes to prior authorizations and claim denials and things like that. There is an adversarial relationship between patients, insurance companies, and providers that is just absolutely silly. And so we are actually really starting to think about what are parts of our technology we can leverage into the provider practices, and how could we send televisits to the hospitals and to our docs in a day off, maybe, as opposed to other doctors sitting and waiting. How could we share much more of our own information that we have with the provider networks? And I think over time that needs to also lead to better financial incentives in the system. So much more pay for performance and pay for value, of course, and some bundle payments as opposed to fee for service. And so I think where it's going to go.
Dr. Shulkin?
I think the question is, what do we think is going to happen, and where's the focus? I have to say honestly, I have no idea, and that's why I'm having so much fun, because you have to check. I'm going to have to get somehow on your website or something what happened in the last 18 hours. Things are dramatically changing. I think the things that I'm trying to pay attention to, if I ever could answer the question correctly, are as Mario's been talking a lot about, what is happening with consumerism? Is the high deductible plan, is this information going to change the way that people utilize healthcare? What's happening with the employers and the private exchanges? Are the employers going to stay with a belief that they need to be involved in people's healthcare, or are they just going to outsource it, essentially, which a private exchange is? I think that the technology issue, I am expecting a big technology disruption. I just don't know what it is, but I think something is going to happen that's going to fundamentally change the delivery of healthcare. I think the provider-payer relationships are a big unknown. Frankly, I would love to make you irrelevant, but I don't think I can. I think that you have to begin.
We would love to help you making the other payers irrelevant.
Yes, no. Right. But I think that these are going to be partnerships, and they're going to develop. But I think overall, and I always preface this by saying I'm almost always wrong about every prediction I make. I think that where I think we're headed in this country is a two-tiered system, just like the Europeans have, where everybody in the country is going to have a certain level of access and benefits to healthcare, as it should be. And then there's going to be a new market developing for people who want different levels of service, different levels of access, a hepatitis C drug that's covered, et cetera. And I think that we're heading to a two-tiered system.
Dave Knowlton?
I've been in the healthcare world for 4 decades, I guess. And during all 4 decades, everybody talked about the healthcare crisis. But they never used the term right. Crisis comes from the Greek. It means a turning point, time of great opportunity and great danger. And people are ignoring the danger here. There's a real danger. The Affordable Care Act was designed to default to a single payer system. Excuse me, it was designed by Ted Kennedy, really. That's why it was in Massachusetts to begin with. And it will default to that system, I don't think productively, but I think it will default to that system if we take a protectionist view of what's happening here. We cannot sustain this system at 18% of the gross domestic product. It's not sustainable. So there are three imperatives in healthcare now: cost, cost, and cost. This other stuff, I love to, I'm the preacher of quality, but it's cost, cost, and cost right now. And the real question is going to be, can we grind that cost down? And we're talking about a 15% drop in cost basis. Now, I don't know if there's pharmaceutical executives out here, does Johnson & Johnson want to tell their stockholders they're going to face a 15% drop in the cost basis of their company? It's rethinking the design of the healthcare system so that cost basis doesn't change. And that's going to be true for hospitals. It's going to be reinventing the hospital. It's going to be reinventing delivery of care. It's all these things. These are big challenges. This is a real crisis point in the classic definition of that, with great, great, great opportunity and significant danger.
Great, thank you. We have about 10 minutes left, and I want to open the floor to questions from the audience. Mike Kopko here and Allison here have mics, and so just raise your hand, and please introduce yourself when you ask a question.
Excuse me, I want to tell you this is an excellent hospital, having experienced it on many continuums within my family, so thank you. And I think you touched on it at the end, and it's a little unfortunate, but with the Affordable Health Care Act flooding new people into the system, and enormous cost drivers for all these great technological things that we want to do, my question is kind of twofold. I mean, number one is, what's happening? We're not talking about the doctors and the providers. I mean, people don't even want to go into medicine anymore because they're not getting paid by the health insurance companies. They're not sure that, why would I spend $1 million in 6 years learning neurology to save a life and get paid $300 for it? At the same time, so the question was, what do you see happening in terms of healthcare providers, and how do you even make it sustainable when you've got the flood in the system? And I don't know. I don't even know how to pose the question appropriately.
Yeah. I'm not as pessimistic about the future of healthcare professionals in the way that I think your question poses. Medicine is changing, but the good news is that people who haven't entered medicine yet that are training never knew the old days. So it's the older doctors that you hear complaining the most about. It's gotten much harder. We're not making as much money as we were, but when you're young, that doesn't really matter because they haven't experienced it. So we're seeing nationally medical school applications at all-time highs. We're seeing medical schools opening up all over the place. Just one announced here in New Jersey. Morristown will be doing something similar in the near future. So I don't think that the people now who essentially have to make that type of dedication, I think still are going to be interested in doing that, and I don't fear that. I actually fear the opposite. There are many, many groups out there that are saying that there are large doctor shortages. I'm probably more with Dave, which is saying, I think that there's going to be a big oversupply of doctors because the role of doctors is going to change significantly. The not only the televisits, but the technological disruptions that are going to happen, I think are going to eliminate the need for a lot of these doctors. Now, maybe not as much in the proceduralists, the people who are doing invasive stuff, but I heard your comment about primary care, and I may not like it, but I may not disagree with what you're saying. So I think young people are resilient. They want to do good. I think you're seeing this new generation really wanting to do good, and I think we'll have plenty of supply coming forward.
Hi, Matt Schwartz. I am a member of the Morris Chamber. And I guess we're not naming names, but we all heard recently about a large insurance company with a cyber issue. And And I'm just wondering how you view that risk. When I see, first of all, when I saw the presentation that you did, we were nodding to each other how impressive it is. But the first thing that I thought of is that if I have one-click access to all this information, so do the Chinese. And just if you could comment on that.
Yeah, absolutely. That's a horrifying data breach for sure. That the industry suffered there. I think to me, really, it's one advantage of being a new company as opposed to a sort of old, stodgy company with 30-year-old systems, which is what many insurance companies and many, frankly, participants in the healthcare system generally are. We have had situations where even the regulators, not to name anybody there either, asked us to put files with claims and personal information onto insecure FTP sites, for example. So the states generally of technological security in the entire system is not very high. Not as high, and this is somewhat ironic, as, for example, in the world of the Facebooks and the Googles. And this is now why I actually think we're in a very good position when it comes to data security. All of our engineers, all of our security engineers actually come from Tumblr, Facebook, Google, and so on. And the guy who literally runs our systems and keeps them up has dealt previously with a website that has 100 million visits in any given month. That is very, very different than anything that this big insurance carrier, for example, that you're alluding to here, has ever faced in terms of internet and web traffic. And so I do think new entrants in the space, if they do their job correctly, are in a better position to secure data than some of the existing systems, which I really would also say are worrisome in terms of stability and worrisome in terms of security. This will not be the last breach we're going to see in the system.
I just want to make a comment about this too, just because when I first came to Morristown, my director of security here at Atlantic suggested strongly, and so I listened to him, that I actually go and attend what's called the FBI Citizens Academy. I don't know if any of you have heard this. This is for leaders. Have you done this? Yes. Okay, so he's an alumnus of this. So I spent 9 weeks with the FBI, where they essentially take us and they take us through all of their operations, and you end up on the SWAT team at Fort Dix shooting machine guns with the FBI. And as I was doing this, I was thinking, why?
Scary for
yeah, exactly. Yeah. No, I was thinking, why am I doing this? And secondly, why does the FBI want to invest all this time in me? And what they said, this was several years ago, they said that the Chinese government in particular was looking to hack into healthcare databases, and were putting a considerable amount of resources into this. And they wanted people like me to be aware of how significant a risk this was and to be aware of this. Now, at the time, I thought, that's crazy. And then I watched the news this morning, and the FBI thinks that this was the Chinese. This is a very high target in healthcare, and we have to be very, very aware of that. So
I don't want to elongate the answer, but I have to add one thing. From a consumer standpoint, the advocacy, your concern and your advocacy is well placed, but it needs to be placed on getting government and regulators to control the information, not to say, gee, I don't want to give them that information, because what you know can save your life. So getting this data out there from a hospital standpoint, from a plan standpoint, from a consumer standpoint is very important. What we need to do, as David suggests, is train people better on how to protect again and get rid of these old legacy systems that are sieves in terms of getting information.
I think it's really right. I mean, again, if we, as an insurance company, we have tons of audit requirements, tons of HIPAA requirements and so on. The regulators audit us on certain things in our databases. They don't audit us on data security. Yeah, so it's just not part of the protocol right now, and that needs to be the case.
They really need to do that.
We have time for one more brief question. Saw in the back here.
Doctor, with all due respect, I feel the same way Lauren just did. I've had my family pass through this hospital many times for many different reasons. Been very pleased with the service. My big question is, we talked about transparency and controversy. That's my biggest issue with the hospitals, and it has to do with cost. There's no standardization as you go from hospital to hospital, whether it be local, statewide, or national. An example, if somebody needs aspirin, in one hospital they may charge you $50, in another one they'll charge you $400. That to me is the real problem with, and the real issue with healthcare costs. It needs to be standardized somehow, some way. I don't know how it's going to get done, but it needs to get done.
Listen, I'm not defensive about this. Our industry has done a terrible job of this. We have lots of excuses for it, some of them which are rational, some of them which aren't. But I think that these high deductible plans are going to put such significant pressure on us to stop the practices of being non-transparent that, that some in the industry are going to figure that out, and it's going to be a competitive advantage to essentially have people understand what they're paying for. I hope that we'll be one of those early adopters to take advantage of it, but I couldn't agree more. Even people who are at very senior levels in healthcare organizations have hard times understanding their own bills. I mean, so I think it's a very fair comment.
All right, thank you everyone for coming. Thank you to our fantastic panel. Really appreciate it.